Hello, everyone, and welcome to the New Jersey Department of Health Maternal Health Awareness Day webinar. In my 3 years as New Jersey's First Lady, maternal health has become my greatest priority. And while this issue has been a serious and dangerous health problem for a long time, it would not have gotten the attention it requires without the work and dedication of Ryan Hansen. Ryan was a loving husband and a new father to a 6-year-old baby boy named Brandon when his wife Tara died of infection from giving birth. In 2012, Ryan created the Tara Hansen Foundation and has been working ever since to raise maternal health awareness and to improve communication between patients, healthcare providers, and family members. Since then, partners in academia, medical professional associations, and New Jersey's 3 maternal and child health consortia have come together each year on Maternal Health Awareness Day with a call for action to address maternal mortality and morbidity and to eliminate the racial disparities that drive our maternal health crisis. The proclamation for Maternal Health Awareness Day in New Jersey was first signed on May 11, 2017, and reaffirmed by Governor Murphy in January 2018. 1 year later, I launched our maternal and infant health initiative, Nurture NJ, on Maternal Health Awareness Day 2019. Through all of this, the stories bravely shared by mothers who lost or nearly lost their lives or their babies have remained heartbreaking and urgent reminders of what is actually at stake. But the statistics are just as disturbing. The United States has the worst maternal mortality rate among all comparable economically developed countries, and New Jersey is ranked 47th out of all 50 states for maternal health outcomes. Even worse, a Black mother in New Jersey is 7 times more likely than a white mother to die of maternity-related complications. And a Black baby is 3 times more likely than a white baby to die before his or her first birthday. These shocking statistics represent the real families who inspire our work. As we continue our effort, we must treat this crisis as if every mother we lose is our mother and every baby we lose is our baby. When we make this issue personal, when these statistics cease to be numbers and instead are our own mothers, aunts, sisters, daughters, and friends, it becomes impossible not to be moved by the urgency of this crisis. And it also becomes clear that the reasons for our Black maternal and infant health crisis are many, complex, insidious, and entrenched, which is why we need everyone at the table. Over the past few years, we have worked to improve communication and build Nurture NJ's network of stakeholders through initiatives like our Black Maternal and Infant Health Leadership Summit, family festivals, quarterly interdepartmental meetings, and more. We understand that the only way to truly solve this crisis is through partnership and collaboration. It is critical that this work continues beyond our administration. To set up New Jersey for long-term success, we have partnered with the Nurture NJ Funders Collaborative to develop a comprehensive strategic plan that includes specific, actionable recommendations for all stakeholders. The Nurture NJ strategic plan is the culmination of over a year of in-person and virtual meetings with our departments and agencies, health systems, physicians, doulas, community organizations, and most importantly, mothers and their families. It is designed to make transformational change in a system that has historically failed our Black mothers and babies. Accordingly, the plan requires all sectors, health, education, housing, business, government, justice, and more, to play an integral role in its realization. Ultimately, the success of this plan relies on the partnership and collaboration of all stakeholders. Our goal is clear: to make New Jersey the safest and most equitable place in the nation to deliver and raise a baby. With that goal in mind, in 2019, the governor signed into law a groundbreaking package of bills, including one that established the New Jersey Maternal Care Quality Collaborative, the New Jersey Maternal Data Center, and the Maternal Mortality Review Committee, and instructed the committee to annually review and report on rates and causes of maternal mortality and morbidity in New Jersey, as well as to recommend improvements in maternal care. With the work of these various organizations, the release of our plan on Monday, January 25th, and the partnership and collaboration of all of you viewing in this webinar, we are one step closer to reaching our goal. And so I thank you for your commitment to every mother and every baby here in New Jersey. And now it is my pleasure to introduce Denise Anderson, Executive Director of the New Jersey Maternal Care Quality Collaborative.
Thank you, First Lady Tammy Murphy, for that awesome welcome and introduction and your unwavering leadership and support in reducing maternal morbidity and mortality in New Jersey, which includes decreasing the racial inequities in maternal health. The Maternal Health Innovation Team consists of the highly skilled and passionate team members seen and not seen on this slide that reflects the diversity of New Jersey. We have our Maternal Care Quality Collaborative Medical Director, Dr. Donnelly Campbell, our Maternal Care Quality Collaborative Nurse Consultant, Brandy Wooding, multiple project managers, Abiola Animashan Amuta, Renee Krause, Mildred Mendez, and Kristen Colburn, research scientists and epidemiologists, Genevieve Leyland Raymond, Aaron Mayo, and Ajra Nantwi, and an administrator, Sonia Gracia, and a host of other maternal health champions within the Department of Health, to include but not limited to Assistant Commissioner Lisa Asari, Director of Population Health, Yanai Kranzler, Executive Director of the Office of Minority and Multicultural Health, Amanda Medina Forrester, Policy Advisor, Jennifer Farron, Director of Maternal and Child Health, Marilyn Gorney Daly, and many more. Next slide, please. New Jersey Department of Health received the 5-year State Maternal Health Innovation Program Cooperative Agreement funded by the Health Resources and Services Administration in September 2019, and we are currently in year 2. We are one of 9 state-focused demonstration projects. The impetus of the program is to assist states in collaborating with maternal health experts and optimizing resources to implement state-specific actions and address disparities in maternal health and improve health outcomes, including the prevention and reduction of maternal mortality and severe maternal morbidity. So, how are the participating states to achieve improvement in maternal health outcomes? Through the establishment of a state-focused maternal health task force, known from here on out as the New Jersey Maternal Care Quality Collaborative, or MCQC, and the implementation of a strategic plan, which will be the Nurture New Jersey Strategic Plan, soon to be released. Moreover, through the collection, analysis, and application of state-level data on maternal mortality and severe maternal morbidity, and by promoting and executing innovation in maternal health service delivery. You will hear a brief description of each of these strategies during this webinar. Next slide, please. Now I will describe the Maternal Care Quality Collaborative, or MCQC, with a little more detail. In 2019, Governor Phil Murphy signed legislation to formulate the Maternal Care Quality Collaborative, the Maternal Mortality Review Committee, and the Maternal Data Center, as mentioned by First Lady Tammy Murphy. Each of these entities are individual strategies in maternal health innovation. The Maternal Care Quality Collaborative cannot possibly have representation of every public and private stakeholder in this imperative work to reduce maternal morbidity and mortality, but it does have diverse representation as per the legislation. Members of the MCQC will represent state agencies, the Maternal Health Consortia, hospital associations, medical societies, the Family Planning League and Planned Parenthoods, regional health hubs, federally qualified health centers, and others. Next slide, please. The goal of the Maternal Care Quality Collaborative as the state-focused maternal health task force is to improve maternal health outcomes by catalyzing multidisciplinary collaboration, collecting and analyzing maternal health data, and promoting and executing innovation in maternal health service delivery. How will we measure progress towards goal achievement? The answer is through specific, measurable, attainable, relative, and timely objectives to reduce pregnancy-associated death, pregnancy-related death, severe maternal morbidity, and racial and ethnic inequities in 5 years. We have our work cut out for us. As a means of level setting, a pregnancy-associated death is a death during pregnancy or within 1 year of the end of pregnancy from a cause that is not related to pregnancy. One example is a pregnant person who dies from a motor vehicle accident. A pregnancy-associated death is a death during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. An example here would be death from a postpartum hemorrhage. Next slide, please. New Jersey's Maternal Care Quality Collaborative will promote women's health, work towards preventing risk, inform providers and healthcare leaders, raise awareness in the identification of early warning signs in providers and pregnant persons, and work towards averting potential obstetric emergencies. The charge of the 34-member committee is to champion and promote buy-in to the strategies and all other efforts aimed at improving maternal health outcomes. The MCQC is also tasked with implementing the Nurture New Jersey strategic plan and translating data into action. Action can be in the form of additional public policy. Action can also be in the form of enhancing current maternal and child health programs or creating new programs that will meet the needs of New Jersey's mothers, children, and families. And last but certainly not least, the MCQC is tasked with soliciting additional funding opportunities that will facilitate the sustainability of what is working here in New Jersey and that will support the development of new initiatives as identified. Next slide, please. The last point that I would like to make about the MCQC is its charge is to use data to inform action. In this slide, I have displayed some of the data elements that will inform action, and I have differentiated action at the system provider levels and at the consumer level. Certainly not all of the data that will be used to inform action, but significantly weighted data sources will be the Nurture New Jersey Strategic Plan, the New Jersey Maternal Mortality Review Committee, and the New Jersey Maternal Data Center. And our action arm at NJDOH are really stratified into two sections. We have action at the provider and system levels, supported by the Maternal Health Innovation Team in the form of implicit bias training, establishing maternal levels of care, the piloting of shared decision-making tools, improving the interoperability of the Perinatal Risk Assessment Plus, and increasing the availability and uptake of long-acting reversible contraception. The consumer action arm resides in our sister unit, Maternal and Child Health Services, that provide direct services to women, children, and families to include but not limited to community health workers, doulas, women, infant, and children, home visiting, and chest feeding. I will now turn it over to Renee Krause, Maternal Mortality Review Committee Project Manager.
Thank you, Denise. The Maternal Mortality Review Committee is the next strategy in our maternal health innovations work. The same 2019 legislation that established the Maternal Care Quality Collaborative also established the Maternal Mortality Review Committee as a formal committee under the oversight of the Department of Health. It authorizes the Department of Health to obtain pertinent data and records related to maternal health care and services for maternal deaths, as well as provides legal protections for committee members who participate in the review process. The data and recommendations will be reported and integrated with the work of the MCQC and the Maternal Data Center. The overall goals of the MMRC are to better understand maternal mortality trends in our state, to identify risk factors associated with maternal deaths, and to make recommendations to the MCQC, state legislators, and other leaders to improve maternal health care. New Jersey has had a maternal mortality review team in some form for over 80 years. In August 2020, we relaunched the MMRC in compliance with the 2019 legislation discussed in the last slide. Our 24-member committee is made up of clinical providers such as OBGYN doctors, midwives, anesthesiologists, and clinical specialists, as well as community health providers such as providers from federally qualified health centers, nurse-family partnership, leadership from the Maternal Health Consortia, and many more. Each month, we meet to review cases. This review process is part of an ongoing quality improvement cycle. As you see on this slide, we identify cases, select cases that meet the criteria to review, abstract all available health records, perform our case review, and then use these findings to make actionable recommendations to improve maternal health care. Through the multidisciplinary contributions of the MMRC, Department of Health staff, and ultimately the MCQC, we hope that we will be able to better understand the specific drivers of maternal deaths and determine what interventions will have the most impact at the patient, provider, facility, system, and community levels to prevent future deaths. We enter the committee decisions and recommendations into a CDC national database called the Maternal Mortality Review Information App, also known as MARIA. The Maternal Mortality Review is a strictly guided process that uses de-identified case information to identify possible factors contributing to a maternal death and make recommendations that inform continuous quality improvement initiatives. The review process is not a mechanism for assigning blame to hospitals, patients, or providers, a robust peer-reviewed research study, or a substitute for hospital-based perinatal reviews and quality improvement initiatives. The MMRC makes recommendations for improvements at the patient, provider, facility, system, and community levels. As you can see from the examples on this slide, some recommendations are specific to the pregnant population, while others would also improve care for patients across all demographics with different health needs. All patients in New Jersey could benefit from having access to substance use screenings using a validated tool at their clinical visits, and also from having a warm handoff to community resources and social services from the clinical setting. The committee aims to make their recommendations actionable by stating who should make the improvement, what is the recommendation, and when should this intervention or change occur. The examples on this slide could apply at the provider, facility, or system level, depending on the scope of the finalized recommendation. The scope of the intervention matters because some of these recommendations can be implemented with a change in practice at the provider level, but others may benefit from a formal written policy or training at the facility or system level. I will now hand the presentation off to Audra Nantry, our maternal and child health epidemiologist.
Thank you so much, Renee. I will be discussing the Maternal Data Center and the New Jersey Maternal Health Hospital Report Card. Here's the current legislation regarding the establishment of the data center, which I will discuss further on the next slide, please. In recent years, the New Jersey legislature passed 2 laws meant to improve data reporting and transparency in maternal health care in New Jersey. The first one was to annually publish the New Jersey Maternal Health Hospital Report Card. The goal of the report card is to provide information to New Jerseyans across the state about the maternal health care provided in all New Jersey licensed birthing general acute care hospitals. The 2016 and 2018 reports are currently available on the DOH website. The report card provides information such as delivering mother demographics, cesarean delivery rates, and select delivery-associated complications. The second law requires the DOH team to establish the New Jersey Maternal Data Center, which provides data regarding maternal morbidity, mortality, and racial disparities to hospital. The data center is currently being developed by the DOH team, but once it's established, it will focus on 3 goals, which include informing on development and assessment of track and quality improvement activities, providing shareable data and information to various stakeholders such as the MCQC, the MMRC, and hospitals to inform and coordinate their activities across the state. And lastly, to publish data that will allow interested stakeholders to assess various areas of interest, such as racial or ethnic disparities in specific maternal health indicators. Next slide, please. Currently, the DOH team is working on the 2019 data for the Maternal Health Hospital Report Card, which is tentatively scheduled for the release of summer of 2021. Concurrently, as part of the maternal data center development, the team is working with various stakeholders to develop a robust set of maternal healthcare metrics to report using readily available data sources. Additionally, development of IT infrastructure to link, store, and analyze the data is currently ongoing. Some of the current challenges with the report card center around questions regarding the usage of the dashboard. The DOH team is considering using web analytics to monitor the utilization of the report card, as well as expanding it to more potential audiences by translating it to different languages. In regards to the New Jersey Maternal Data Center, some of the challenges include the currently available data being too limited to accurately describe the status of maternal health care, as well as being able to report on certain metrics that are hindered due to privacy concerns. There's also lots of coordination involved to develop a proper infrastructure that adequately addresses some of the technical aspects involved in linking and analyzing large sets of data. In terms of next steps, the DOH team continues its work on the next iteration of the report card, as well as continued conversations with stakeholders to develop the appropriate metrics and how they are reported going forward. Next, I'd like to hand it over to Mildred Mendez, the project manager for implicit bias training.
Thank you, Audra. New Jersey is poised to pass implicit bias legislation that will require every labor and delivery hospital and birthing centers licensed in the state to implement an evidence-based implicit bias training program for all healthcare professionals who provide perinatal treatment and care to pregnant women at the hospital or birthing center. Next slide, please. The New Jersey Department of Health has undertaken the development of an implicit bias training that will be made available to labor and delivery facilities and birthing centers throughout the state. The training will be a two-phased anti-racism approach that will incorporate an e-learning webinar and a quality improvement training for champions of change. The purpose of the training will be to inform on how healthcare systems have historically and negatively contributed to Black women's health outcomes and disparate morbidity and mortality rates. The training will focus on the implicit and explicit biases contributing to disparities experienced by Black pregnant women in New Jersey. It will also highlight ways that can reduce disparities in maternal health and demonstrate the positive effects of providing culturally sensitive, patient-centered, and evidence-based care delivery. Next slide, please. During phase 1, a multi-module e-learning webinar on systemic and racial inequities will be developed and made accessible to all clinical and non-clinical staff of all labor and delivery hospitals, birthing centers, and federally qualified healthcare centers in New Jersey. The implicit bias webinar will advance understanding of the historical and present-day impact of structural racism on health outcomes, explore how conscious and unconscious bias influences communication and decision-making. The participants will learn specific professional and personal strategies that can mitigate detrimental effects of racism and unconscious bias, and it will also encourage healthcare providers to identify internal systems that may be contributing to disparate outcomes. Next slide, please. During phase 2 of this initiative, we will develop a train-the-trainer quality improvement curriculum to educate on identifying workplace policies, protocols, or procedures that contribute to negative health outcomes for pregnant Black women. The curriculum will be used to to train self-selected champions of train. The goals will be to provide attendees with the understanding of a need for quality improvement, to build sustainability of trainings by continuously training hospital champions to address quality improvement initiatives, improve service and program delivery, and can provide positive impact to the communities they serve. I will now turn this over to my colleague, Brandy Wooding, who will talk about shared decision-making. Thank you.
Thank you, Mildred. In 2019, shared decision-making legislation was enacted supporting the voluntary adoption of shared decision-making tools in all maternity and birthing hospitals, with the impetus to improve the patient's knowledge, increase patient-provider collaboration, improve the patient's overall experience, and encourage the patient to have a birth plan that would incorporate their preferences through labor, delivery, and postpartum. Next slide, please. So what is shared decision-making? It's a collaborative process that keeps the patient at the center of every healthcare decision made. In shared decision-making, both the patient and provider work together to select tests, procedures, and ultimately develop a plan of care that takes into consideration the patient's specific values, preferences, and needs while balancing the risk versus benefits. Next slide, please. Shared decision-making aids, also referred to as shared decision-making tools, offer a consumer-friendly visual accompaniment which supports a patient's informed choice. They can come in the form of pamphlets, brochures, checklists, electronic algorithms, and so on. Shared decision-making aids or shared decision-making tools highlight the patient's specific condition, provide evidence-based options along with the available treatments. At this time, I'm going to turn it over to my colleague, Kristen Colburn, Project Manager for the CDC Locate. Thank you.
Thank you, Brandy. I'm going to introduce our work to establish risk-appropriate care for maternal health. As a little background, risk-appropriate care is a strategy developed to improve health outcomes for pregnant women and infants. The goal is to align the capability of healthcare facilities with patient risk so that patients are receiving care that meets their needs. We're familiar with risk-appropriate care in New Jersey as perinatal levels of care, i.e. NICU levels at hospitals. These perinatal designations have helped New Jersey develop coordinated systems of care to address the needs of infants. However, maternal health is not comprehensively accounted for in these levels. With rising rates of maternal mortality, it is imperative that we establish risk-appropriate care specifically for maternal health. To accomplish this, in addition to assessing perinatal levels of care to address infant health, we are proposing to also adopt maternal levels of care to more comprehensively address maternal health and mortality. Next slide, please. To help us assess the care being provided across the state, we will be implementing the CDC Levels of Care Assessment Tool, or LOCATE. The LOCATE tool is a web-based survey that asks the facility questions about facility statistics, volume of services, personnel, patient care protocols, and transport. We are working with the CDC as well as the New Jersey Hospital Association to deliver, collect, and analyze these survey results. In the coming months, birthing facilities will receive the survey along with education and technical assistance for completing the survey. We will then work with the CDC and stakeholders to assess levels of maternal and perinatal care based on updated standards from the American Academy of Pediatrics and the American College of Obstetricians and Gynecologists. We are really excited about this important work and the prospect of creating a more coordinated system where pregnant persons receive the care that aligns with their needs. I'll now turn it over to Abiola Animashan-Amuta, Project Manager of the MCQC.
Thank you, Kristen. So now I'll be focusing on the Perinatal Risk Assessment Plus tool. So as we've heard earlier on the call, data is an important part of how we can move forward with addressing maternal mortality and morbidity in New Jersey. One out of many tools that the Maternal Health Innovation team will be using is the Perinatal Risk Assessment Plus tool. This tool, supported by Family Health Initiatives in Southern New Jersey, is a standardized tool that aims to capture information pertinent to the pregnancy at two specific points, once during the first trimester and once during the third trimester. It's important to note that the PRA Plus focuses on Medicaid beneficiaries only. Data is collected by managed care organizations, or MCOs, and agency partners, and entered into a separate data system called MHAD to help identify maternal needs during pregnancy, to help providers make appropriate referrals, and to triage care coordination for mothers using Medicaid throughout their pregnancy. Our colleagues within maternal and child health services also use the data from PLAR Plus to give guidance and activities recommendations in their program, Healthy Women, Healthy Families. Next slide, please. While the PRA Plus is an excellent tool, we also recognize the areas for improvement and optimization. With that said, we hope to focus on the following improvements over the next several months, including upgrading the technical infrastructure that hosts the PRA Plus for increased accessibility and interoperability, mainly focusing on how to incorporate the tool into the New Jersey Health Information Network, or NJHIN. We also like to focus on how to auto-populate certain sections of the PRA to decrease data entry burdens and to reduce errors that may come up with human error. We'd also like to focus on how we can improve care transitions within the PRA Plus, because there isn't an area for that currently within the assessment tool. We'd also like to focus on developing a PRA Plus provider dashboard so we can easily disseminate results in real time for providers. And we'd also like to focus on convening on a PRA collaborative stakeholders series of meetings to develop quality improvements and metrics. Additional improvements may also come from improved synergies and lessons learned for the Maternal Data Center and other tools as mentioned earlier on the call. Now I'll hand it back over to Denise.
Thank you, Abiola. Now to briefly discuss increasing access to long-acting reversible contraceptives, or LARC. So, long-acting reversible contraception, or LARC, can be an implant placed under the skin or an intrauterine device or system that is placed in the uterus, known as IUDs, intrauterine devices. According to a report published by the New Jersey Healthcare Quality Institute in May 2020, there are barriers at the consumer and provider levels regarding LARC. For the consumer, there is financial access, so insurance or lack of insurance. And even with insurance, barriers include co-insurances, co-payment, and deductibles. There's also mistrust, fear of side effects, language and cultural barriers, and confidentiality concerns. At the provider level, there are barriers as it relates to availability of contraceptives of choice, pre-authorization and billing, and knowledge about LARC and or the skills to insert them. Next slide, please. The LARC Maternal Health Innovation Strategy will examine increasing facilities' ability to stock devices, training providers on LARC billing and insertion, and raising consumer awareness on LARC and family planning. I'll now turn it back over to Brandy Wooding.
Thank you, Denise. Project ECHO, or the Extension for Community Health Outcomes, is a collaborative way to address healthcare disparities through an interactive virtual platform. Project ECHO is a way for providers to share best practices, the latest evidence, and to create collaborative communities where knowledge is increased. Next slide, please. An ECHO series can include up to 12 individual sessions, with one session occurring every other week. The sessions typically last 60 minutes, but can be adapted to meet the needs of the audience. Each session is typically led by one or more experts. It's a collaborative environment where questions and comments are encouraged, and learning may also be substantiated with case studies. All sessions are HIPAA compliant. Next slide. Some of the benefits of Project ECHO include creating a collaborative environment that promotes lifelong learning. It enables people in underserved areas to receive the care and support that they need. It provides a broader network of expertise and access to that expertise, and it promotes more and better services to patients. Next slide, please. New Jersey is fully committed to its efforts to decrease infant and maternal mortality and morbidity while ensuring health equity for all. In conjunction with the First Lady Tammy Murphy's Nurture New Jersey campaign, the state has also focused on 10 strategies to improve maternal and infant outcomes throughout the state of New Jersey. A future ECHO series will elaborate on each of these strategies. And at this time, I'm going to turn it over to my colleague, Dr. Donnelly Campbell, the MCQC Medical Director. Thank you.
Thank you, Brandy. My name is Donnelly Campbell Aparagy. I'm a practicing obstetrician in Newark, New Jersey. I am also serving as the medical director for the New Jersey Maternal Care Quality Collaborative. Each one of us wears many hats. Not only am I a healthcare provider, but I am a consumer and I am a community member. And as you can see, despite the challenges we faced in 2020 and those to come, the Department of Health remains committed to prioritizing improvements in maternal health, as well as reducing health disparities that we see in New Jersey. Many of you may be familiar with the pictorial where everyone is given equally. This pictorial from the Institute of Perinatal Quality Improvement reminds us that in this diverse world we live in, one size does not fit all. Some individuals may require different resources to ultimately reach the fruits of their labor. It reminds us that in all this work, we must infuse health equity to reduce the existing disparities. You can see here over time, the recommendations from the MMRC have changed to reflect, in some degree, the prevalent causes of maternal mortality in the state of New Jersey. In one example of how we want to take data and move it to action is in substance use disorder. In more recent maternal mortality reviews, opioid overdose deaths amongst pregnant and recently postpartum women have exponentially increased in a similar fashion to what we have seen in the general population. While substance use disorder rarely starts during pregnancy, the vast majority of women are able to stop any substance use or alcohol use when they find out they're pregnant. But there are stresses that occur during pregnancy and stresses that occur postpartum that can lead to relapse and exacerbation of substance use disorder. And so early identification of women with substance use disorder can allow for earlier and greater opportunities for treatment and linkages to a variety of resources that are needed at this important and critical time in a person's life. Healthy People 2020 called for a 10% reduction in cesarean section rate amongst low-risk women. In this slide, we can see from 2016 to 2018 that the cesarean section rates have remained steady. The First Lady and the Surgeon General have both identified this as an area of concern, and particularly for the low-risk cesarean, nulliparous, term, singleton vertex. As a practicing obstetrician, I know that cesarean can be life-saving, but with the increase in cesarean section rates that we see without a decrease in maternal morbidity and mortality, we have to examine this trend more closely. Cesarean is a tool that we want to make sure we are using most appropriately. And so reducing cesarean section rates is already on the radar for so many hospitals. And why focus so much on cesarean birth? We know that when we look at morbidity and mortality, cesarean birth is more likely to be associated with delayed recovery, increased risk for infection, bleeding, amniotic fluid embolism, thromboembolic events such as blood clots, and future cesarean deliveries. In addition to preventing the first cesarean delivery where possible, we also need to focus on offering trial of labor after cesarean for those appropriate candidates, offering or referring patients for external cephalic version in cases where the baby is in a breech presentation, and using the revitalized definitions for failed induction and arrest of labor. I would encourage all of us to, especially healthcare staff, to watch the webinar on promoting, protecting, and supporting physiologic birth. Improving labor support is essential to improving maternal outcomes. Doulas, nursing education, and integration of mental health resources into maternity care is vital. Out of the 700 women who die each year in the United States, 40 to 50 of them are from New Jersey. 2 in 3 deaths are preventable. The Hear Her campaign from the CDC is designed to make sure that family and friends are listening to women's concerns and not just dismissing them. I would encourage you to view the YouTube video referenced here. The CDC website has information geared towards pregnant and postpartum women, separate information geared towards partners, friends, and families, and yet different information geared towards healthcare providers. So just a little bit more detail about how we get to this mission of making New Jersey a safer place. So far, no one I have talked to disagrees with this mission, but how do we get there? There are many stakeholders who are involved, and so the names here are not all inclusive. It will certainly take all of us, but it will take all of us working synergistically together. My grandmother always said, many hands make the work light, and there's no I in team. The what is our priority strategies, and once we improve these, we can move on to others. We need to employ strategies that promote health equity and help pregnant people feel that their values and views are being heard. Using the data to inform our actions, up-to-date information on the causes of morbidity and mortality will enable the development of the programs that will ultimately impact individuals and their families. Institutions need timely data as well to inform them of quality improvement projects. When? There is an urgency of now. We can't wait. A woman dies from the complications of childbirth in the United States every 12 hours. So whether we call it Taylor ham or pork roll, whether we call it a sub or a hoagie, whether we live near exit 1, exit 98, or exit 150, New Jersey's diversity stretches beyond geography. It includes, but is not limited to, racial and ethnic diversity, modes of access to transportation, socioeconomic status, and much more. And we know that economic status does not make you immune to the issue of maternal morbidity and mortality, especially among pregnant people of color. We must leverage strategies that have worked in similar communities, whether they are located in the north, in the central, or the southern part of our state. We can and we must be collaborators and share best practices. Why? Why not? We all may have many different reasons for doing this work. And I simply ask you, why are you driven to work on maternal health? Why you care? And I invite us all to write down your why on a Post-it note. Stick it on your computer, stick it on your wall, put it in your wallet, put it on your bathroom mirror, or wherever you are right now in front of you as a source of inspiration. For me, it was the selection of medicine as a profession and wanting to help others. And from our MHI team, you can see here some of their whys for doing this work. The Surgeon General's call to action makes it clear that we all have a contribution to improving maternal health. Everyone can raise awareness about the early warning signs, support healthy behaviors like physical activity, breastfeeding, and smoking cessation. In our state and in local communities, we can create environments that promote good health for all, eliminating food deserts, creating green spaces, and improving public safety equitably in all communities. Healthcare professionals can ensure quality preventative care for all and address health disparities. Hospitals and health systems, birthing facilities can participate in perinatal quality collaboratives, provide comprehensive discharge instructions and warm handoffs when needed, and train non-obstetrical staff about postpartum and obstetrical emergencies. Payers can promote access and incentives for healthcare across the lifespan and align their financial incentives with improvement in maternal care for all races and ethnicities. Employers can play a key role in supporting working parents, supporting breastfeeding by providing lactation spaces and break time. Breastfeeding mothers are happier and spend less time when they're not home caring for sick children. And innovators can promote coordination across healthcare professionals and systems. Researchers can expand and develop sufficient evidence on medications and treatment in pregnancy and lactating women. And we need research to support and understand, prevent, and reduce adverse maternal health disparate outcomes. The list is by no means all-inclusive, but it's meant to emphasize that we are all needed at the table. Harambee is a Swahili word that means let's all pull together. So as we close today's program, where we are lifting up maternal health awareness, I invite us in this new year to all pull together in unity, peace, love, health, wellness, family, happiness, which I believe are core values that all New Jerseyans want for themselves and for their loved ones. Thank you for joining us today. For more information about the Maternal Care Quality Collaborative and the work of the Maternal Health Innovation Team here at DOH, or feedback on this presentation, please feel free to contact one of my DOH colleagues listed here.